Before I start my class, I'll just introduce myself. Probably the first time that I'm taking classes for you all. My name is Dr. Vijay Nongpiur. I'm assistant professor in TB and respiratory diseases, and uh, as if I'm not wrong, probably this batch is the 2016 batch, right? So most probably you would not have met me. I was here before till 2014 rather, as an SR in medicine. Now I've come back as assistant professor in TB and test after doing my DM in AIMS. So today I'll be talking about non-tubercular mycobacterial infections, especially pulmonary NTM diseases. You may get NTM infections as a short question, may even come. If you're unlucky, it may come as a long question in your exams. Okay, so today's class, the outline, basically I will describe an actual case scenario, which was one where we had treated back in AIMS when I was doing my DM. Then then we'll go into the introduction, the history, classification of NTM disorders, the epidemiology of NTM, non-tubercular mycobacteria, the different diseases and their presentations, how do you approach the diagnosis and the treatment. So coming to a case, this was of a 53-year-old male. He was from Jabalpur in Madhya Pradesh. He was a non-smoker. He does not take any alcohol without any comorbidities. And according to his file, he had a history of tubercular effusion in 1997. Then he presented to AIMS on with complaints of fever, cough with expectoration, weight loss, and loss of appetite since 2012. And in fact, in throughout 2012 and 2013, he received 13 months of empirical ATT without any symptomatic improvement. And so, if you can see, this is his chest X-ray. Showed significantly destroyed lung. You can see the trachea has been pulled to the right side. There's a lot of pleural thickening here, most likely because of the old effusion, and they also infiltrates in the left mid-zone, and the significant hyperinflation, compensatory hyperinflation of the right side. So we got a CT scan done for this patient, and as you can see in the mediastinal window, we can see that definitely there's a shift of the trachea to the right side. And then we have extensive pleural thickening with possible cavitation here in the right middle lobe, and also a bit of consolidation here, which is seen easier in the lung window. We can see a thick wall cavity here with irregular borders, and also a lot of consolidation, extensive consolidation in the left lingula. So he was evaluated outside, and outside the sputum was positive for AFB on multiple samples. So what would be the most likely diagnosis? For our first diagnosis, basically we just go by the sputum AFB, the CT picture, and the history of tubercular effusion in the past. We would probably think of tuberculosis. But again, clinically, if we go back, we see that they received ATT for more than a year, in fact for 13 months, but there's been no response. So we'll have to think of other diagnoses. And among these, NTM lung disease would be a possible differential. So what are NTM non-tubercular mycobacteria? So as we all know, the scientific classification of mycobacteria, they from the phylum Actinobacteria, of the family Mycobacteriaceae, and of the genus Mycobacterium. So this is an electron microscopic picture of the of a mycobacteria. So the important thing about all mycobacteria are that they are mycolic acid containing genera. That's why they are AFB positive. They are aerobic, they are non-spore forming, they are non-motile, they are gram positive on gram stain, and they were discovered for the first time in 1882 by Robert Koch. Okay, and there are more than 200 species of mycobacteria. So history of non-tubercular mycobacteria. In 1868, tuberculosis was first described in chickens. Then in 1882, Robert Koch made the discovery of mycobacteria. In 1890, there was a discovery in the lab to be distinct from Mycobacterium tuberculosis, but this organism was not, the identity of this organism was not yet known. Then later on, it was identified to be as Mycobacterium avium. Then in 1943 was the first known case of Mycobacterium avium intracellular lung disease, and in 1950 the pulmonary disease due to non-tubercular mycobacteria was finally established. So if we look at overall classification of mycobacteria, you have the three major classifications: the Mycobacterium tuberculosis complex, you have your Mycobacterium leprae, and then you have your non-tubercular Mycobacteria. The Mycobacterium tuberculosis complex is further divided into your Mycobacterium tuberculosis, your Mycobacterium bovis, and the BCG, your Mycobacterium africanum, Mycobacterium mycoti, Mycobacterium caneti, and caprae. Then you have the Mycobacterium leprae and the non-tubercular Mycobacteria. So this is an important classification of the non-tubercular mycobacterium. This was famously known as the Runyon classification, where the non-tubercular mycobacteria are first divided into the slow-growing mycobacterium and the rapidly growing mycobacterium. The slow-growing mycobacterium are further divided into the chromogens, that is the pigmented mycobacterium, or the non-chromogens, or the non-pigmented mycobacterium. Among the pigmented mycobacterium, you have the photochromogens. That means they release a yellow-green pigment on exposure to light, and the scotochromogens, that is they release the pigment irrespective of any exposure to light. Even when they are not exposed to light, they will still release the yellow-green pigment. Then among the non-pigmented mycobacterium, we have the Mycobacterium avium intracellular complex and the non-my mycobacteria. So Runyon classification as further, the basis of this Runyon classification is that the photochromogens are classified as Runyon 1. They include Mycobacterium kansasii, Mycobacterium marinum, and Mycobacterium simiei. Runyon 2 are the scotochromogens, that is those that produce light rapid. They are slow growing mycobacteria who produce who produce pigment irrespective of the presence or absence of light. They include Mycobacterium scrofulacum and Mycobacterium gordonii. Now Runyon 3 is the non-pigmented slow growing mycobacteria, which include the MAI complex. The MAI complex is further subclassified into the Mycobacterium avium and Mycobacterium intracellular, and the other NTMs are Mycobacterium zenopi, ulcerans, terrae, and malmonsi. Then you have the Runyon 4, which is the rapid growing mycobacterium, which include Mycobacterium fortium, Mycobacterium clenoi, and Mycobacterium abscessus. So this is an important classification to know. You can either take a photograph of it, or you can, if you have it, if you can copy. If not, take a snapshot of this, because this is an important classification which most of you may be asked. You may even be asked for a short note on the Runyon classification. Okay, so in total there are more than 160 species of NTM identified, of which around 50 species are associated with lung disease. I will not go into the details. The other names from non-tubercle bacteria which you may see often are atypical mycobacteria, environmental mycobacteria, MOTT. This is another very common term, MOTT, that is mycobacteria other than tuberculosis, or PPEM, that is potentially pathogenic environmental mycobacteria, anonymous mycobacteria, or the most commonly used term, non-tuberculous mycobacteria, or NTM. Now, NTMs are ubiquitous in the environment, with the heaviest concentrations found in water and soil. Risk factors. Now, since they are ubiquitous, everyone is presumed to be exposed to NTM. Okay, but most of us do not develop any significant signs of any infection. So, who are the ones that develop infection due to NTM? So, for a person to develop clinically apparent signs and symptoms of NTM requires a distinct interaction between the host, the environment, and also the mycobacteria. As you know, the mycobacteria have a number of defense mechanisms. They have the lipoarabinomannan, which induces pro-inflammatory cytokines and induces neutrophil influx. There is a waxy envelope which offers resistance to antibiotics and also resistance to the innate immune responses of the body. And they also multiple glycopeptidolipids, which allow the bacteria to generate biofilms. It allows in their motion. It cloaks the bacteria from antigen presentation. So all these factors help the mycobacteria to persevere within the host. And if by any chance the host's immunity somewhat decreases, it may be because of any chronic infection or any antecedent cause for fall in the host immunity, that's the time when the NTM infection may become apparent. So what are the host factors which are important to know? HIV infection. HIV infection is important count, especially when the CD4 count is less than 50. They are at a high risk of developing NTM infections. Others include structural lung disease. Any damage to the lung parenchyma resulting in a change in the structure and architecture of the lung, such as COPD, silicosis, pneumoconiosis, prior history of TB, bronchiectasis, cystic fibrosis. These are important causes of these. In these instances where there's structural damage to the lung, the altered structure of the lung will anyway alter the local immune environment within the lung. So all the defense mechanisms within the lung, such as the ciliary motion of the airways within the lung, they all will be altered. This leads to this allows the mycobacteria to grow and multiply within the lung. In fact, in cystic fibrosis, almost 4 to 20% of patients of cystic fibrosis will eventually have MAC or Mycobacterium abscesses infection in their lifetime. Pulmonary alveolar proteinosis is another important cause, structural cause of NTM infection. Older age, male gender, and also reflux. So chronic immunosuppression, such as post-transplants, especially in post heart and lung transplants, post bone marrow transplants, or even those with autoimmune disorders who are on TNF alpha inhibitors. As of now, we know that TNF alpha inhibitors are extensively used in diseases like rheumatoid arthritis and other connective tissue disorders. So these, especially the use of TNF alpha inhibitors, poses a great risk for the development of not only Mycobacterium tuberculosis but also non-tubercular mycobacterial infection. Then, so the epidemiology of NTM, basically like I said, the most important sources are soil and water. Spa, showers, and pools commonly have MAC isolates. They are resistant to conventional decontamination. As you know, they have a cell wall, they have a biofilm. So physical decontamination usually they are resistant to. Then, and there is no evidence of animal to human or human to human transmission of non-tubercular mycobacterial infections. Okay. So this is a small chart which shows the geographic diversity of non-tubercular mycobacteria isolates from pulmonary samples. Worldwide, this most common is still MAC, followed by Mycobacterium, followed by RGM, then followed by the Mycobacterium gordonii. Whereas in Asia, we see that again MAC is still the most common organism, followed by RGM and also by gordonii, and other slow-growing mycobacteria are also seen. This is another similar thing. This is basically, we all know that MAC is basically a complex of Mycobacterium avium and Mycobacterium intracellular. So this is the distribution of MAC. Among MAC, the most common is still Mycobacterium avium, both in worldwide and Asia. Whereas in Asia, we have the entire complex to be second most common. Whereas in the rest of the world, we have Mycobacterium intracellular to be more common. So the clinical manifestation of NTM infection, basically there are 4 forms. It can be a chronic pulmonary disease, it can be a lymphatic disease, disseminated disease, and also post-inoculation. So pulmonary disease is most common clinical manifestation. Lymphatic disease usually occurs in young children, occurring most frequently in the second year of life. Disseminated disease is commonly present in those with severe immunosuppression, such as in HIV/AIDS, and post-inoculation is usually present as skin and soft tissue infections, or post-surgical wound infections, or post-injection abscesses. So pulmonary manifestations of NTM disease, the most common clinical manifestations of NTM disease is chronic cough, sputum production, fatigue, malaise, dyspnea, fever, hemoptysis, and weight loss. So as you can see here, these symptoms are also very common to, very similar to tuberculosis. So that is why clinically is very difficult to distinguish NTM from tuberculosis, as this they are also AFB positive. So in this study, which was done in 2008, we've seen that cough with phlegm, that is productive causes, cough is one of the most common presentation. But in addition, we also have, if you look at here, we have night sweats and also weight loss, which are also commonly associated with tuberculosis. So just by history and symptoms, it is very difficult to distinguish NTM from tuberculosis alone. Now, In the lung, the NTM may present as a fibrocavitary disease, nodular or bronchiectasis disease, or a hypersensitivity like lung disease. Fibrocavitary disease usually occurs in patients with pre-existing structural lung disease, such as those with COPD or other structural lung diseases, such as silicosis, pneumoconiosis, or prior TB infections, where has been a scar or a granuloma which is already present in the lung. It is more common in the older populations, especially in males. And since this is a cavitary disease, the most common symptoms will be productive cough, weight loss or weakness, and also fever with night sweats. Now, this is a nodular or bronchiectatic presentation, also known as Lady Windermere syndrome. Lady Windermere syndrome. This is, if you see this picture, this is the classical picture of an upper class lady in the United Kingdom during the 1800s, where they have this very tight corset. So the chronic use of these tight corsets, it causes them to have a structural deformity within the rib cage, almost causing it to become funnel shaped. So that's why they develop pectus excavatum, scoliosis, thin body habitus, and also have MBP. So these usually present characteristically with infiltrations within the right middle lobe or the lingular, or the left side, the lingular lobe. They can either present as nodules or bronchiectasis. So any right middle lobe bronchiectasis or right middle lobe nodules, which is suggestive of which on microbiological diagnosis is suggestive of NTM, we can label them as Lady Windermere syndrome. Hypersensitivity due to NTM is also known as hot tub lung disease. That's the another colloquial term for them. Basically, it is hypersensitive reactions to a non-tubercular mycobacterial antigen. It occurs in persons exposed to swimming pools of heated water containing MAC and showers or aerated symptoms. Then is usually of a subacute onset and presents with dyspnea, cough, and fever, and occasionally may develop hypoxemic respiratory failure requiring admission to the hospital. So the radiological manifestations, again, depending on the type of NTM infection, whether it's fibrocavitary, whether it's bronchiectatic, nodular, or whether it's hypersensitivity, like, the radiological manifestations will differ. So if you look at here, this is this particular chest X-ray shows a this small thin wall cavity here in the right upper zone on this chest X-ray, and this is a nodular presentation of an NTM with a small cavity here, extensive centrilobular nodules all over in the periphery, and also there is slight cylindrical bronchiectasis here in the airway. Okay, there's extensive bronchial wall thickening. Here you can see that the bronchial wall is extensively thickened. So similarly here, we can see that there is volume loss on the right side. The horizontal fissure has been pulled up, and there is extensive nodular infiltration here. There's another X-ray of NTM disease showing multiple thin wall cavities here. There's another cavity here with a granuloma or a nodular lesion here. Here you can see multiple cavities with on the right upper zone and mid zone. There's a bit of bronchiectasis, and also we'll have a nodular lesion of increased opacity on the left upper zone. Similarly, you have a solitary pulmonary nodule due to Mycobacterium avium intracellular. This is the progression of disease that can happen. There's already significant destruction of the parenchyma that can be seen in the right upper and mid zone, and also extensive bronchiectasis and fibrosis which has developed with time in untreated NTM disease. Okay, so that's similar. Here we find pulmonary manifestation due to Mycobacterium kansasii, where you can see a thick irregular wall cavity, and also extensive centrilobular nodules. So this is a nodular variant, and whereas this is the fibrocavitary variant. Okay, so this is what we call as the Lady Windermere syndrome, where they can develop either a right middle lobe or a left lingular bronchiectasis or nodular infiltration. Here you can see extensively in the medial segment of the right middle lobe, and here in both the medial and the lateral segment of the right middle lobe are involved. So this is the radiological picture of the so-called Lady Windermere syndrome. Okay, so that is Lady Windermere syndrome. Okay, so this is again nodular opacities due to MAC, which are mimicking malignancy, especially if you look at these lesions here. Okay. So if you look at these lesions here, this particular one, this one, you find that they have heterogeneous. The opacity is heterogeneous. So that is why they can sometimes be confused on radiological imaging as a tumor or a malignancy, and hence tissue diagnosis or microbiological diagnosis is very important for these, for achieving a correct diagnosis. Now, this is another disseminated MAC infection presenting as a huge mediastinal mass here, and also may even present with a classical miliary type of a picture. Okay. So this is hypersensitivity pneumonitis, which is the so-called hot tub lung disease. Here you can find extensive centrilobular nodules. There's preservation of lung volume, no significant fibrosis, but there's extensive centrilobular nodules in this lung picture. So this is hypersensitivity due to NTM disease, also known as the hot tub lung disease. So can we differentiate tuberculosis from NTM clinically and radiologically? So if we look at it, thick wall cavity consolidation, randomly distributed nodules, pleural effusion are more common in TB, but can also be seen. Now, what can be seen in both in NTM and TB is nodular infiltration, tree-in-bud appearance on CT, consolidation, lymphadenopathy. But what is more common in NTM is thin wall cavity with hotline nodules, bronchiectasis, especially with a middle or upper lobe predominance, bronchiectasis or bronchiectasis with cystic changes. These are more commonly seen with NTM disease. So laboratory diagnosis. Now, many NTM species such as Mycobacterium gordonii are generally non-pathogenic and almost invariably represent as contamination rather than any pathogenic organism. Now, NTM can be found in potables, that is municipal or tap water, so they can be a source of waterborne contamination of the specimen rather than disease. The recovery of even a potentially virulent or pathogenic NTM may be associated with the absence of any active or progressive disease. And the diagnosis of NTM lung disease does not really necessitate the institution of therapy. We have to take many other factors into consideration: how symptomatic the patient is, and whether there is anything that may propagate the lung disease, such as a chronic condition in the patient, chronic immunosuppression, structural lung disease, which may cause progression of the disease. Then in such case we may necessitate therapy, otherwise we may even just wait and watch. So if you remember the first two slides, I've shown you the CT of this patient who had received ATT for more than a year with no response. Sputum was still positive, AFB. Subsequently, GeneXpert was also done. GeneXpert, as we know, is a molecular assay for tuberculosis, which was negative. This all the more points to something which is AFB positive, but not necessarily Mycobacterium tuberculosis. So NTM is strongly considered here. And then, we sent cultures to both the NITRD, that is LRS Institute in Delhi, and also at AIMS, and the MTB culture had grown that they were. So the culture for the sputum had grown Mycobacterium clinoi and Mycobacterium abscessus, which are non-tubercular mycobacteria. And DST of this sample showed that they were already resistant to isoniazid, rifampicin, ofloxacin, and clarithromycin. Okay, so this was the resistance was expected since they had already received extensive treatment. So obviously there was a higher chance of developing drug resistance. So, laboratory diagnosis, microscopy, again, sample from non-sterile body sites, you can decontaminate it by the NALC, NaOH method, whereas sterile body sites, decontamination is not required. Non-sterile, ideally, the smear microscopy will be usually similar to TB, except that here you collect 3 early morning specimens on different days preferred. You can screen by fluoramine, the fluorochrome, that is ormine, so which is here. This is how they will grow, and they can be confirmed by ZN staining, where you get this acid fast status. Now, you should know that AFB, like I said, cannot differentiate between Mycobacterium tuberculosis and non-tubercular mycobacteria. So in such cases, you need nucleic acid amplification tests for the detection of Mycobacterium tuberculosis if required, such as that which was done for our case, where he was AFB positive, but when we did the GeneXpert primarily looks at genes which are specific to tuberculosis. That's why the GeneXpert was negative. Culture remains the gold standard and also required for genotypic identification and drug susceptibility testing. So different culture media that we have: solid media, you have the LG medium, the Middlebrook 7H10 and 7H11. These, like all just as for TB, they also, it takes a lot of time, at least 3 to 4 weeks, before we can get any really definitive result with the culture. For liquid medium, you have the Middlebrook 7H9, and the automated now, which is what is preferred now, is your Midget 960 and the Bactec system. So Midget 960, basically the Midget stands for Mycobacterium growth indicator tube. So this is here, that means Midget takes as early as within 2 weeks for any signs. If there's any signs of growth, we can know as early as by 10 days to 2 weeks. So what happens is that so the mycobacteria, the culture media, the culture is actually put in small tubes and they're incubated, and there is radioactive, if I'm not mistaken, I think it's radioactive carbon, which is then seen by a gamma ray, by a gamma camera, and if there is growth, then this radioactive carbon is released, which is then picked up by the gamma camera. So that is why it's known as a Mycobacterium growth indicator tube. It indicates whether there is growth, any growth of Mycobacterium within these culture tubes. Liquid systems are more sensitive and reduce the delay in detection of NTM, but are prone to contamination by other microorganisms. All cultures of NTM should include both your liquid and solid media, and using both will increase the sensitivity of NTM detection by almost 15%. So how soon do we assess for culture? 1 week for rapidly growing and 2 to 3 weeks for slow growing NTMs. So as you probably would remember from your days in microbiology, Mycobacterium, the characteristic description is your buff and rough colonies, which also we call them as the breadcrumbs of cauliflower. Whereas here we have the Mycobacterium monacea, Mycobacterium cheloni, and Mycobacterium kansasii, which has the characteristic red pigment. Okay. In addition, you also have your biochemical test, where the non-tubercular mycobacteria are niacin negative and catalase positive, whereas TB is niacin positive and catalase negative. So it is exactly opposite of non-tubercular of Mycobacterium tuberculosis. Okay, now next is the MPT64 antigen, which is significant, which is able to discriminate between Mycobacterium tuberculosis and NTM. This is more specific for non-tubercular Mycobacteria. Okay, so the algorithm is you do a sputum AFB smear and a sputum culture, and then what you can do is you can do a TB antigen with MPT64 rapid antigen test, and that will tell you whether it is Mycobacterium tuberculosis or NTM. Okay. Then NTM species identification, you need a phenotypic system. You can do a phenotypic testing, biochemical testing, high pressure liquid chromatography, mass spectrometry, and nucleic acid based testing. I will not go into the details of these. Basically, we have, for molecular methods which are more important, we have line probe assays, polymerase chain reactions, and DNA sequencing. The only FDA approved test is the acronym Aster labeled DNA probes, which are specific for MAC, kansasii, and Gordonay only. Okay. They are based on the release of target 16S rRNA from the organism, and these target genes are the HSP65 and the RPOB gene. So for the evaluation of NTM disease, the minimum evaluation of suspected NTM lung disease should be a chest radiograph. And if it is not really suggestive, you can go ahead and get an HRCT chest also. 3 or more sputum samples for AFB staining. This will be a screening assay, excluding other disorders like TB or malignancy. And most cases, the diagnosis can be made without bronchoscopy or lung biopsy. If required, if it's still in doubt, we can go ahead with these more invasive measures. Now, the diagnostic criteria of NTM lung disease. This is based on the American Thoracic Society and Infectious Disease Society of America guidelines of 2007. So you need both a clinical and a microbiological diagnosis. Your clinical is your pulmonary symptoms, and along with that, your chest X-ray, which is showing nodules or cavities, or an HRCT, which is showing multifocal bronchiectasis with multiple small nodules, and an appropriate exclusion of other diagnosis. So you have your symptoms, and also you exclude other diagnoses such as MTB or other immunosuppressed disorders. Then you have your microbiological diagnosis, which is positive culture results from at least 2 separate expectorant sputum samples, or a positive culture results from at least 1 bronchial wash or lavage if bronchoscopy has been done. Transbronchial lung biopsy or any other form of lung biopsy with microbacterial histopathological features and positive culture for NTM. So you can do a lung biopsy also, and that you can send it both for histopathological examination and also for culture. So that is positive. Or the biopsy showing microbacterial histopathological features and 1 or more sputum or bronchial washings that are culture positive for NTM. So NTM lung disease, you need to have both a clinical diagnosis and also a supporting microbiological diagnosis. So this patient again, so November 2015 when he came to us, he was really bad, and then he was started initially treated with HRZE, so isoniazid, rifampicin, pyrazinamide, and ethambutol along with levofloxacin and clarithromycin until the culture and DST were available. And as you saw in the culture and DST, it was resistant to ofloxacin, to basically quinolones and macrolides. So his regimen was changed to linezolid, clarithromycin, ethambutol, ferropenem, and amikacin for the initial 2 months. Okay. So treatment of NTM, what we need to know: management of NTM disease is a challenge to every physician that is there. The diagnosis of NTM does not obligate the initiation of therapy. Like I said, just the presence of NTM does not mean that we have to treat all of them. We can afford to wait and watch. Unlike pulmonary TB, clinicians may observe patients with minimal symptoms. Then treatment durations, once we start, is around 12 to 24 months, and almost we need to sample them at least every 1 to 2 months and do a DST if required to look for any form of drug sensitivity which may necessitate a change in our treatment regimen. So what are the options that we have in treatment? We have your macrolides, rifampicin, ethambutol, aminoglycosides, isoniazid, fluoroquinolones, doxycycline, minocycline, linezolid, imipenem, sulfonamide, cefoxitin, and on the other side we have surgery. Okay. So when we look at the MAC lung disease, which is Mycobacterium avium intracellular lung disease, the mainstay of treatment is of course macrolides, which is either clarithromycin or azithromycin. Only macrolide DST correlated with clinical response. The standard optional regimen is rifampicin, ethambutol, and a macrolide administered for 18 to 24 months, including 12 months of sputum negativity. That means you can go from 18 to 24 months, and of which the last 12 months, at least 1 year, the patient has to be sputum negative and continue treatment for 1 year after he has turned negative by sputum. So there's also a question of whether you want to give the treatment daily or intermittent, thrice weekly. They found that in the daily regimen you have clarithromycin, azithromycin at clarithromycin at 1 gram per day, azithromycin at 250 mg per day, ethambutol at 15 milligram per kg, rifampicin at 600, and duration of 24 months. Whereas the intermittent therapy was higher dose of azithromycin at 500 mg, 25 mg per kg of ethambutol. Okay, so we find that intermittent 3 times weekly therapy with a macrolide, rifampicin, and ethambutol is a reasonable initial treatment for patients with non-cavitatory nodular bronchiectatic MAC lung disease. So the mainstay will be a macrolide, and so the mainstay will be macrolide, clarithromycin more than azithromycin in cases of MAC. Then monotherapy is not recommended. You should always use a combination therapy, and the preferred combination therapy is clarithromycin plus ethambutol plus rifampicin. Okay, thrice weekly regimen can be used in patients without any risk factors for adverse outcomes. Aminoglycosides can be used for cavitative disease or disseminated disease, and fluoroquinolones can be added as a second line. So when we come to Mycobacterium kansasii, it's far more far more responsive, drug responsive organism than compared to MAC. The presentation is similar to pulmonary TB with fibrocapillary lesion in the upper lobes, and the recommended daily regimen is daily isoniazid, say 300 mg per day, rifampicin 600, and ethambutol at 15 mg per kg for 12 months. For 12 months after sputum culture conversion. As we know, for NTM disease, once we start treatment, we have to at least do a sputum culture every 1 to 2 months to see when do they sputum convert, and from then we then go on for another 12 months of treatment. Okay, so Mycobacterium abscessus and Mycobacterium macilliense, the They are the most common rapid growing mycobacteria. They usually present with nodular bronchiectasis. Okay, they have poor outcomes and there is paucity of treatment. They are very resistant to treatment. So the current guidelines suggest an oral macrolide with 2 parenteral agents for several months to symptomatically improve and slow down the disease progression. And the most active parenteral agents include amikacin, cefoxitin, imipinem, or tigecycline. Okay, so this is the recommendation. This is the treatment recommendation for NTM, MAC pulmonary disease, whether it's nodular or bronchiectasis disease, you have clarithromycin, ethambutol, rifampicin. Fibrocavity lung disease, you have clarithromycin, ethambutol, rifampicin, with or without aminoglycoside, depending on how severe the disease is. Advanced or previously treated disease, then we can add instead of we can add clarithromycin, ethambutol, rifabutin, and aminoglycoside for at least 2 to 3 months. Here we have to add, for advanced or previously treated disease, we have to add at least 4 drugs. For Mycobacterium kansasii, isoniazid, rifampicin, and ethambutol is enough. Abscesses, we have clarithromycin and 2 parenteral agents. We can choose from amikacin, cefoxitin, imipinem, or tigecycline. Now, like I said, patients should be treated until culture negative on therapy for at least 1 year. For refractory NTM lung disease, refractory is defined as failure to convert sputum to AFB negative, culture negative for after at least 6 months of recommended therapy. So what are the drugs that we have that we can change? We can add amikacin either in IV or inhalational route. Inhalational route has lesser adverse effects, especially on the kidneys, and liposomal amikacin inhalation is more effective than your conventional amikacin. Linezolid, there's again limited data. Tigecycline is like tigecycline is a bacteriostatic drug. It's not a bactericidal drug. Clofazimine we can add, which has also been used for MDR-TB. Bedaquiline has been considered, which showed, and bedaquiline has also been has shown to have a 60% microbiological response with 90% of symptomatic improvement. Surgery. So when do we do surgery for NTM lung disease? When there is significant drug resistance or for failure of medical treatment. When there's significant drug resistance and localized lesions, what we do is with surgery we can do either a lobectomy or a segmentectomy or a wedge resection, remove only the affected part. That will also decrease the bacterial burden and also help to facilitate effective chemotherapy. Debulking basically is when there is already significant disease. We want to slow down disease progress. When you know that there is not much, when you see that there is not much response to chemotherapy, we can slow the disease progression. We can remove the disease portion of the lung. We can even go for a whole lobectomy if the other lung is if the other lung is not really affected. We can do an entire lobectomy. And in cases of hemoptysis, such as in a large cavity, we have a large cavity with significant uncontrolled hemopsis, not responding to conservative treatment, or we've even tried interventional procedures like we've tried embolization and other techniques, but there's still active hemoptysis from that, then we can go for surgical resection of the affected segment of affected area of the lung. Okay. So hypersensitivity pneumonitis or the hot tub lung disease, this is more commonly seen. It's another commonly seen disorder. Here, usually you can observe, but in patients with severe disease or respiratory failure, you have to start steroids. You can give at 1 to 2 mg per kg per day, tapered over 4 to 6 weeks. Then antimicrobial therapy may be required in immunocompromised patients with persistent disease, even after removing them from the antigen exposure, or patients with bronchiectasis. So steroids you can give for a total duration of 3 to 6 months. Usually they respond well to steroids alone. I'm coming, but the meeting will end in 5 minutes. Okay. So this patient has now till 17th of March, March of 2017, when we had seen him. Here there was significant improvement. Also, although there is residual structural changes within his lung, but there has been significant improvement. He's been asymptomatic on minimal cough. Sputum has been culture negative since March 2016, and he has received a total duration of 24 months of treatment. So in conclusion, all AFB positives, you have to remember all AFB positives are not tuberculosis, especially if there have been no response to treatment. Diagnosis and treatment of NTM lung disease is often a challenge to the physician. Culture remains the gold standard diagnostic test for NTM disease. MAC is the most common NTM worldwide. Rapid growing NTMs are the most common NTMs in India. Macrolide remains the mainstay of treatment, but monotherapy is to be avoided. You always have to have a combination therapy, and multi-drug therapy multi-drug therapy for at least 12 months beyond sputum culture negativity is the recommended duration of treatment. And refractory NTM may require second-line antibiotics, and even surgery may be needed in a few scenarios. Okay, thank you.